Good evening. Hello. So, hope all you are doing well and you are preparing very hard. I know that's a very crucial time is going on. So, I will not take much of your time and I will directly come to the point. And first, I will just brief you that how we are going to proceed. I have selected some of the very important high yield topics and the interrelated things that is going to cover majority of the things for your upcoming exam. So let's get started. When it comes to the the aromatic amino acid, we know that the aromatic amino acid, there are four examples of the aromatic amino acid: tryptophan, phenylalanine, tyrosine, and histidine. How we used to remember in the class, if there is fan in the name, that is going to be aromatic. Tryptophan, phenylalanine, and what was the smell? That was tyrosine. Now, what is the point to be remembering in this? The most important question to be remembered is there are these aromatic amino acid which tends to absorb the UV rays, and the maximum UV absorption. This is the important question. Maximum UV absorption it is seen with which amino acid? Tryptophan. Tryptophan. I will emphasize the words again and again whenever I will say, see, I will tell you that whenever we'll discuss a topic, I will tell you this is the most important thing. If this word will come, this will be the answer. The most, the amino acid which have the maximum UV absorption, tryptophan. Let's move to the next one. Now, here we are going to discuss the biosynthesis of urea. First, we need to understand why we are synthesizing urea. What is the reason of synthesizing urea is, see, whatever protein we are eating, that protein will break down into amino acids. This amino acid will further break down into ammonia. Now the problem is ammonia is a very toxic molecule. So we need to convert that into urea, and this urea will be excreted out in the urine. So this is why we want to synthesize the urea. This conversion of ammonia to urea can occur only in one organ, and that is liver. So what we are dealing with here is we are learning that why we need to synthesize urea, because when you cut the amino acid, the protein will, so when you cut the amino acid, the ammonia will come. This ammonia has to be converted into urea and that will be thrown out. How it is happening? See, if we see the various steps, whatever protein you are eating, this protein will break down into amino acids, and these amino acid what we are going to do is we are having 22 different types of amino acid. These 22 different type of amino acid, we will convert them into one particular type of amino acid, that is glutamate. See, over body tissues, for our convenience, we are going to divide into two: liver, hepatic tissue. The remaining tissues are the extrahepatic tissue. So what is happening in the extrahepatic tissue? The protein will break down. You will get different amino acid. We will convert all the amino acid into a single type of amino acid. That is called as glutamate. So this process is called as transamination. Once you did this, this glutamate will travel via the blood and it will come to the liver. It will come to the liver. Why we are sending all the things into the liver? Because liver is the only factor which can convert ammonia into urea. Now what the liver will do is, out of this glutamate, we are going to take out the ammonia. The ammonia will be taken out and this ammonia will be here in the liver, which will convert into urea. Now, here is an important question that sometimes what happens is in the extrahepatic tissue, a small amount of free ammonia is directly present. And we also need to send that ammonia to the liver. For example, in my brain, there is a small amount of ammonia. And the conversion we know that only can occur in the liver. So we need to send that ammonia into liver. The question is, what is the name of the transporter by which we are going to send the ammonia to the liver? What is the name of the transporter from brain? It is glutamine. From the brain, how we are going to send the ammonia to the liver is with the help of glutamine. It's a very important MCQ, the name of the transporters. I will tell you the summary. Then, how we are going to send the ammonia from the skeletal muscle and the other tissue, it is with the help of alanine. So, these are the two important transporters of ammonia. And now the ammonia has came into the liver. And once it will come into the liver, our task is done. The liver is a factory that will convert the ammonia into urea by doing urea cycle. So, four steps of the biosynthesis of urea. What are the four steps? The first, you convert all the amino acid into glutamate, and that process is called as transamination. The second thing that you are going to do is this glutamate will reach in the liver and will take out the ammonia from the glutamate. Third thing is the transporters. the most important question of this flowchart. What is the name of the transporter of the ammonia from brain to liver? Glutamine. What is the name of the transporter from the muscle to liver? Alanine. Once the ammonia will reach, the ammonia will convert into urea with the help of urea cycle. Now let's see the urea cycle. When it comes to urea cycle, there are total 5 steps. You just be with me for next 2.5 hours, something like that. We will make sure that your most of the questions will be correct. And if you will be attentive, I will make sure that you will remember the things in the classroom itself. So the next is how the urea cycle happens. How the urea cycle happens. So the urea cycle, there are total 5 steps. Out of 5 steps, 2 steps in the mitochondria, remaining 3 steps, cytoplasm. Total 5, 2 in the mitochondria, 3 in the cytoplasm. What is the task? Whenever we start any pathway, the task has to be clear. We are going to start with the ammonia and we want to reach all the way till urea. This is the task. We will start from ammonia, we go to urea. The first 2 reaction in the mitochondria. In this, all the process, I will directly come to the point that there are total 5 enzymes. There are total 5 enzymes. They ask that what is the rate limiting enzyme of urea cycle? The rate limiting step means the slowest step of the pathway, and that is CPS1, carbamyl phosphate synthetase 1. It is so lazy that to activate this enzyme, we require activator. And the name of the activator is NAG. N-acetyl glutamate is the activator. So when we will do these 5 reactions, ultimately we are going to get the urea. What are the questions that comes from the urea cycle? It is not the time that we are going to cram the urea cycle, and no one is going to ask that write down the urea cycle. We should know that what are the points that we should know for the MCQ purpose. Urea cycle occurs where? Liver. Which organelle? 2 steps mitochondria, 3 steps cytoplasm. Total 5 steps. Because there are total 5 enzymes, but still they ask sometimes what is the name of the 6th enzyme in the urea cycle. The NAG. NAG is considered as the 6th enzyme. NAG is considered as the 6th enzyme. Then they ask that in the urea cycle, total how many ATPs are consumed to make the urea? 3 ATPs. Or if they ask how many phosphate? 4 phosphate. So, what are the points to be remembered? See here. The points to remember from urea cycle. The first, how much energy is consumed? How much ATP is consumed? 3 ATP. If they ask phosphate, 4 phosphate. Second, what is the rate limiting enzyme? CPS1. If they ask what is the 6th enzyme of urea cycle, NAG is considered as a 6th enzyme of the urea cycle. NAG is considered as a 6th enzyme of urea cycle. Very important question. You know that 2 reactions mitochondria, 3 in the cytoplasm. They ask all of the enzyme of urea cycle is found in the cytoplasm except. And how we are going to remember that? It's very easy. The cytoplasmic enzyme, look at the cytoplasmic enzyme. Arginosuccinate synthetase, arginosuccinase lyase, arginine hydrolase. They all are starting with the alphabet A. So it's very easy to remember. The enzyme which is starting with the alphabet A, they are the cytoplasmic enzyme. Remaining is the mitochondrial enzyme. So urea cycle, the question should not be go wrong in urea cycle. Very few points to remember. How many ATP consumed? 3. How many phosphate? 4. What is the rate limiting enzyme? CPS1. Who is the activator of CPS1? NAG. What is the name of the 6th enzyme? NAG. And the cytoplasmic enzymes starts with which alphabet? A. And that's done. Now coming to the clinical correlation. See here. This is the simple flow chart of the urea cycle which just now we have discussed. We started with the ammonia and we went all the way till urea. These were the 5 steps. Now, if there is problem in this urea cycle, if any of the enzyme is not there, any of the enzyme, let's say CPS1 is not there, then ultimately the ammonia is going to accumulate. Or for that matter, if any enzyme is not there, ultimately ammonia is going to accumulate. So, whenever there is any problem in the urea cycle, the ammonia is going to increase. Means the hyperammonia is going to be there. Hyperammonia will be there. There are total 3 types of hyperammonia that you should know. Total 3 types. Let's start. And out of that 3, the 2 are very important. Hyperammonia type 1 and type 2. What is type 1? If there is a deficiency of CPS1, carbamyl phosphate synthetase 1, it is called as hyperammonia type 1. If there is a deficiency of ornithine transcarbamylase, it is called as hyperammonia type 2. In the exam, how we are going to find that whether they are the patient that they have told us, is it type 1 or type 2? See, hyperammonia, the symptom will be same. Hyperammonia, ammonia is toxic to breathe. So whenever the ammonia increases, the patient feels drowsy. There can be seizures. These are some of the symptoms of there will be slurred speech, decrease in the muscle tone. These are the symptoms of hyperammonia. But how we can differentiate type 1 or type 2? In type 2, in type 2 hyperammonia, there is going to be orotic aciduria. So, if they say, if a patient is coming to us and he is just having hyperammonia, if they are saying that the patient is just having hyperammonia, there is no other symptom, this is hyperammonia type 1, which is due to deficiency of CPS1. But if they say a patient is presenting with us with hyperammonia plus orotic aciduria, the moment you see this word orotic aciduria, it is OTC deficiency. Ornithine transcarbamylase deficiency means it is hyperammonia type 2. So we have two types of hyperammonia and we can easily identify in the MCQ. If they write this word orotic aciduria, it is type 2. If they don't write, it is type 1. It is as simple as that. So this is all about from the urea cycle to be remembered. So let's quickly revise again, because my agenda is very simple to revise here itself in this video, because we won't have the time again because you have so much stuff to do. So let's revise here itself. Urea cycle, where it's going to occur? Liver. 5 reaction, 2 in the mitochondria, 3 in the cytoplasm. How much ATP will be used? 3. If they ask phosphate, 4. What is the rate limiting enzyme? CPS1. Who is the activator of CPS1? NAG. If there is any problem in the urea cycle, that condition is called as hyperammonia. It can be type 1, type 2. If they mention the word orotic aciduria, it is type 2. If they do not mention, it is type 1. Done. The next amino acid we are discussing is phenylalanine. If you see the metabolism of the phenylalanine, for the metabolism of the phenylalanine, we require 2 enzymes, phenylalanine hydroxylase and BH2 reductase. And once the metabolism occurs, what molecule we are going to generate? Tyrosine. Phenylalanine can convert into tyrosine, and that tyrosine can make melanin that will decide over skin color. Now, if there is a child who is not having either of these enzymes, phenylalanine hydroxylase or BH2 reductase, if there is deficiency of any of the enzyme, the reaction will not happen. If the reaction will not happen, what is going to increase? Phenylalanine will build up in the body. Phenylalanine will build up in the body, and increased amount of phenylalanine will trigger alternate pathway. It will convert into its ketone version. The phenylalanine will convert into its ketone version, and these ketone bodies will come in the urine. What are the ketone versions? Such as phenylacetate, phenyl pyruvate, phenyl lactate. They will start coming in the urine. That is why this disease is called as phenylketonuria. The ketone version of phenylalanine is coming in the urine. What is the most common enzyme that leads to most important enzyme deficiency that is leading to phenylketonuria? Phenylalanine hydroxylase. And the ketone version. What are the ketone bodies that are made? Phenylacetate, phenyl pyruvate, phenyl lactate. They will be formed. Now, what is going to happen is this phenylacetate. Now, listen to these words. These are the crucial words. Phenylacetate comes in the urine and it has a very bad smell. Smells like mouse. There is going to be a mousy smell in the urine because of which molecule? Phenylacetate. Phenyl pyruvate is very toxic to the brain. So this child in the future is going to have the mental retardation. And because this reaction is not happening, so there is going to be decrease in the tyrosine. Decrease in the tyrosine means decrease in the melanin. And if there is decrease in the melanin, there is going to be fair complexion. So there are 3 symptoms of phenylketonuria. The child will have a very bad smell in the urine, will have mental retardation, fair complexion. Nowadays, they have stopped writing the word mousy smell. Instead of that, what they will write? The mother is saying that a very bad smell comes whenever I am changing the diaper. The bad smell is there. Instead of the word mousy, what they will write? Bad smell. Bad smell with decreased IQ and fair complexion, phenylketonuria. What is the enzyme deficiency? Phenylalanine hydroxylase. What will be the treatment and what is the investigation? Once it comes to the investigation, the named investigation, just a fancy name, Guthrie test. Guthrie test is done for phenylketonuria. And what is the treatment? The problem need to understand that the child is unable to digest phenylalanine. Don't give him phenylalanine. So nowadays we have in the market phenylalanine free diets available. Give him phenylalanine free diet. So this is all about the phenylketonuria. So let's revise. What are the points to be remembered? First, which enzyme deficiency? Phenylalanine hydroxylase. 3 symptoms: bad smell in the urine, decreased IQ, fair complexion. Why bad smell? This is important. Everyone knows that there is going to be mousy smell, but why? Because of which molecule? Phenylacetate. Because of phenylacetate. Why there is decrease in the IQ? Phenyl pyruvate. And why there is fair complexion? Because of decreased melanin. That's done. And the investigation is Guthrie test. Done. Let's go to the next. Now coming to the next, very important. You remember last time, 30th July, there was 3 questions from this half page. 3 questions. Pheochromocytoma were having 3 questions on 30th July paper. Let's understand what is that. Tyrosine is an amino acid from which we can make the catecholamines, means the norepinephrine and epinephrine, means the other name noradrenaline, adrenaline. See, tyrosine in the chromaffin cells converts into norepinephrine and epinephrine. If there is a tumor in the chromaffin cells, that is called as chromaphinoma. If there is a tumor in the chromaffin cell, that is called as chromaphinoma. The other name of chromaphinoma, pheochromocytoma. Pheochromocytoma. So, if there is a pheochromocytoma, means there is more chromaffin cells, there is a more production of norepinephrine, epinephrine. Norepinephrine, epinephrine, they are the mediators of the sympathetic system. So the sympathetic system will work more, and because of that, the patient will have palpitation, headache, hypertension, sweating. These symptoms will be there. Headache, palpitation, sweating. This is a classical triad. Now, these symptoms will not last long. The reason is the norepinephrine and epinephrine, the half-life is very less. The symptoms will, as soon as the tumor will secrete, the symptoms will come. And within no time, these molecules will be catabolized, the symptoms will go away. So the patient will be like this, that Dr. Saab, for last 6 months, I am having a problem that all of a sudden I start having palpitation, sweating and headache, hypertension. And these symptoms last just for 10-15 minutes. Earlier it was less, but now it's occurring very frequently, troublesome. So he came to you. The moment you see the word episodic, it is going towards pheochromocytoma. Now we know that because in this condition there is more norepinephrine and epinephrine. Whenever there is more norepinephrine, epinephrine, these molecules are break down in the form of metanephrines, and these metanephrines will start coming in the urine. So what is the screening test? That is urine metanephrine level. And what is the investigation of choice? The plasma fractionated metanephrine levels. So you will check these levels and they are going to be high. Now this tumor can be in the adrenal gland or can be sometime outside the adrenal gland. How to localize that? You will do MRI abdomen and you will find that where is the tumor. Then because it's a tumor, the treatment is surgical excision. The first, I told you 3 questions. I will tell you all the 3 questions. Before you do the surgery, the doctor will give 2 medication to be taken for 7 days. The first drug is alpha blocker, that is phenoxybenzamine, that is to be taken first 4 days. Then the remaining 3 days, the second drug will be added, that is a beta blocker. So the question was asked, there is a patient, he is having pheochromocytoma, the doctor has told before surgery he has to take some drug. Which is the first drug to be taken? Alpha blocker. Which are the 2 total drugs? Alpha plus alpha followed by beta blocker. After 7 days you will do the surgery. After doing the surgery, you need to explain the patient that there can be a complication, that your skin color will become dark, pigmentation will happen, and this is called as Nelson syndrome. So these are the 3 questions that came. The second question that came was, what is the complication of the surgery of the pheochromocytoma? Nelson syndrome. Nelson syndrome. How to localize the tumor? MRI abdomen. So these were the 3 questions from the pheochromocytoma. And how it is related with biochemistry? It's pure biochemistry that the norepinephrine, epinephrine, whenever they are in excess, they are synthesized from tyrosine. Whenever they are in excess, when they break down, which molecule is made? Metanephrines. Metanephrines. Let's go to the next one. That is cheese-tyramine reaction. See, just now I told you that tyrosine is the molecule from which we make the norepinephrine and epinephrine. How it is made? Tyrosine converts into dopa, dopa converts into dopamine, dopamine converts into norepinephrine, epinephrine. And these molecules, their effect does not last long. To destroy these molecules, we have certain enzymes. For example, to destroy the dopamine, we have the MAO-B and the COMT enzyme, and they will completely destroy the dopamine. For example, there is a patient, he is suffering from Parkinson and he is taking a drug, selegiline, which is a MAO-B inhibitor. MAO-B inhibitor means this pathway is not working. And by chance, if someone is taking MAO-B inhibitor and on top of that, if he eat cheese contains a lot of tyrosine and tyramine. This cheese, if he will eat, the tyrosine will come, it will convert into dopamine, but now the dopamine cannot be break down. It will increase. A lot of increase in dopamine will increase the norepinephrine, epinephrine, and the patient will have increase in the blood pressure, headache and nausea. After eating cheese, the patient is having these symptoms. This is called as the cheese-tyramine reaction. It's called as cheese-tyramine reaction. Cheese-tyramine reaction, right? So, question kaisa aayega? If they say that the patient is taking a drug If they gave the name, very good, MAO inhibitor. On top of that, he had some cheese or maybe red wine. After that, he is having nausea, vomiting, hypertension. What is the meaning of that? Cheese tyramine reaction. Because there is more sympathetic activity that is happening. Done. Let's see the next. Very important disease, alkaptonuria. See, the tyrosine is catabolized into 4-HPP. Full form is not important because it's not the time to understand the full forms. 4-SL, I will say 4-hydroxyphenyl pyruvate, and that will convert into homogenetic acid. Homogenetic acid can convert into methyl acetoacetate. Now, when this pathway is actually tyrosine catabolism pathway. Whenever we have excess tyrosine, this is how the tyrosine is catabolized. It's converted into this. Now, to convert the homogenetic acid into methyl acetoacetate, we require enzyme Hg oxidase. If this enzyme is not there, the reaction will not happen. And because of that, there is going to be increase in homogenetic acid. If there is increase in the homogenetic acid, it will trigger alternate pathway. As well as there is going to be increase in the tyrosine and all these things. Because it is going to trigger alternate pathway, it is going to make a molecule called as benzoquinone acetate. This benzoquinone acetate will come in the urine and it will lead to darkening of urine on standing, darkening of urine. As well as these benzoquinone acetate crystals are going to deposit in the joint and they are going to destroy the joint cartilage. So this patient is going to have the joint pain. Two symptoms we have already discussed. The patient is going to have darkening of urine and there is going to be joint pain. The third thing that is going to happen is because there is more tyrosine, it is not getting catabolized, the tyrosine will make more melanin, so this patient will have pigmentation. I will tell you 3 questions from here. You just remember this, the task will be done. This disease is called as alkaptonuria. The first question, alkaptonuria is due to deficiency of Hg oxidase. Second question, can you tell me what are the 3 symptoms? Darkening of urine, joint pain, and third is the skin pigmentation. These are the 3. They will ask all of the following are symptom of alkaptonuria except, even I will tell you the 4th answer, the 4th option. 4th option is going to be mental retardation. Mental retardation is not a symptom of alkaptonuria. Either you remember these 3 or you remember directly mental retardation is not a feature of alkaptonuria. Hands done. So, it occurs, generally it is going to be in 3rd, 4th decade. The IQ is normal, there is no mental retardation, the IQ is normal. So there are 3 symptoms, darkening of urine, joint pain, pigmentation, there is no mental retardation. It is alkaptonuria due to deficiency of Hg oxidase. And what is the treatment? The treatment is nitisinone. I am not able to see your chat box because I was just going with the flow so that you will not waste much of your time. Okay, now let's come to the next. The niacin. Niacin synthesis. Niacin means vitamin B3. See, tryptophan is amino acid from which we can make vitamin B3. It is itself a question. They ask like this. There is amino acid which is vitaminogenic. And in the exam, we see this word for the first time, vitaminogenic. ये क्या होता है? Vitamin is very simple, right? From which amino acid we can make a vitamin, that is tryptophan. Tryptophan can convert into niacin. And what is the name of this pathway? This is called as kynurenine pathway. It's called as kynurenine pathway. The pathway is not important, just the name, kynurenine pathway. Now, what happens is sometime there is the vitamin B3 deficiency happens. How? Say, there are some people who are maize eaters. Those who eat a lot of maize contain very less amount of tryptophan. If you eat a lot of maize, tryptophan deficiency will occur. If there is less tryptophan, there is going to be less niacin. And if there is less niacin, this patient will start having diarrhea. This is the first clinical feature of niacin deficiency itself, MCQ. Then this patient will develop the dermatitis. This is one of the most frequently asked image-based question in your exam. That is the castle necklace appearance. And the third, if it is not treated, ultimately there is going to be decrease in the higher mental function, that is dementia. So, what is that? How they are going to frame the question? If there is less tryptophan, there is less niacin, and this disease is called as pellagra. So the question will be, what is the first symptom of pellagra? What is the first symptom of pellagra? Diarrhea. Pellagra always start from GI tract. Then, if not treated, the patient will develop dermatitis. If not treated, the patient will develop dementia. This is called as the pellagra, deficiency of niacin. Why? Because the patient was not eating tryptophan. And how you make the niacin? What is the name of the pathway? Kynurenine pathway. Now, let's understand one more thing here. See, when the blood goes in the nephron, the tryptophan gets filtered. Tryptophan is a neutral amino acid, it gets filtered. But the good thing is, in the PCT, the tryptophan gets absorbed back with the help of SCl6A19. With the help of SCl6A19, the tryptophan, whatever is coming, it will get absorbed. So we don't lose tryptophan in the urine. But if this channel is not working, the tryptophan will be lost in the urine. And if the tryptophan is lost in the urine, the tryptophan will be less, the niacin will be less, and the patient will have the pellagra-like symptom. And this disease is called as Hartnup disease. So what is Hartnup disease? If the tryptophan is lost in the urine, and because of that, the patient is developing pellagra-like symptom, it is called as Hartnup disease. Done. So this is all about tryptophan. So before moving forward, let's just recap about the tryptophan. Tryptophan, we make niacin. What is the name of the pathway? Kynurenine pathway. If there is deficiency of vitamin B3, pellagra. What is the first symptom of pellagra? What is the first symptom of pellagra? Diarrhea. Then dermatitis. Then dementia. And if the tryptophan is losing in the urine, and because of that, the niacin deficiency happens, that is called as Hartnup disease. Done. Let's understand one more thing. See, as of now, what we have discussed is that tryptophan can convert into several special molecules. One of them was niacin. Now, there is one more special molecule which is made by the tryptophan, that is serotonin. We make serotonin also. And this serotonin synthesis, can you tell me it occurs in which cell? Serotonin synthesis, it occurs in the argentaphin cells. So, see here, tryptophan can convert into niacin, can convert into serotonin in the argentaphin cells. And sometimes there is a tumor in the argentaphin cells which is called as argentaphinoma. The other name of argentaphinoma, carcinoid tumor. What is going to happen? If there is a tumor of the argentaphin cells, because there is more number of argentaphin cells, all the tryptophan will come in this direction. And this tryptophan will convert into more and more serotonin. A lot of serotonin will be made. And because the tryptophan is going in that direction, a very less tryptophan can convert into this. So there is going to be deficiency of niacin, means pellagra-like symptom. So a patient of argentaphinoma or carcinoid, how it is going to present? He will have pellagra-like symptom. He will have diarrhea. And because there is more serotonin, serotonin is a vasodilator. The patient will have facial flushing. The facial blood vessel, they will dilate. Facial flushing. And there is going to be bronchospasm. So what are the points to be remembered? In carcinoid, what are the symptoms? How we are going to remember carcinoid is, there is going to be facial flushing with diarrhea. You just remember like this, flushing, diarrhea. Facial flushing, diarrhea, carcinoid. And how we confirm that? If there is more serotonin, whenever there is more serotonin in the body, more serotonin converts into, serotonin basically converts into a molecule called as 5-hydroxyindole acetic acid. 5-hydroxyindole acetic acid. So what is the investigation we do for carcinoid? If you are suspecting carcinoid, check the level of 5-hydroxyindole acetic acid and that will be more. This is what you have to check, right? So we have discussed two diseases related to tryptophan. One, niacin deficiency, pellagra. If there is more serotonin excess, that is called as carcinoid. And this tumor is also called as argentaphinoma. Done? Okay. Okay, let's move forward. Just a simple statement and can be your exam question. Histidine converts into histamine. What is the name of reaction? How the histidine is converted into histamine? We need to remove a carbon dioxide. So what is the name of reaction? Decarboxylation. Remember, let's remember right here itself. Histidine converts into histamine. What is the name of reaction? It is decarboxylation. Done. Let's understand one more thing. There is a histidine metabolism pathway that histidine can convert into imidazole, and that imidazole can convert into a molecule called as FIGLU, form amine glutamic acid. This FIGLU can convert into glutamic acid, and for that we require vitamin B9. Folic acid. Do you know that folic acid deficiency in pregnancy leads to neural tube defect, right? These are the images of the neural tube defect. Folic acid deficiency leads to neural tube defect. So, for example, let's say a 30-year-old female is coming to you and she is telling to you that last child 4 years back had neural tube defect and unfortunately died. Now she is again planning for pregnancy and she wants to make sure that her folic acid levels are normal. What test you will do? What you will do is you will use this concept. You know that histidine converts into figlu. Figlu can convert into glutamic acid. If which vitamin is there in the body? Vitamin B9. So what you will do? You will tell that, okay, we are going to give you an injection that is full of histidine. You will give histidine and after some time, you will check the level of figlu. You will check the level of figlu. If her vitamin B9 level was normal, the figlu would have converted into glutamic acid. But if the vitamin B9 was less, what will increase in his blood? Figlu. And this is how we can check the vitamin B9. This test is called as histidine loading test. Histidine loading test. We are loading the patient with histidine. Done. So, we have discussed 2 points regarding histidine. Let's revise. Histidine to histamine. What is the name of reaction? Decarboxylation. And if you want to check the vitamin B9 deficiency, which test you will do? Histidine loading test. It's a loading test. And what we are going to check? It is the, we are going to check the figlu levels, whether they are increased or not increased. Can you tell me a gynae question that what is the most common type of neural tube defect? Yes, spina bifida. Spina bifida occulta is the most common type of neural tube defect. Coming to the next, that is maple syrup urine disease. See, what happens is the branch chain amino acid, that is live. We have remembered in the classroom, if you remember, that how to remember that to have a branch relationship, the person has to be live-hearted. The person has to be live-hearted. To have a branch relationship, the person has to be live-hearted. So, what is happening here is that the branch chain amino acid, they are metabolized by branch chain alpha keto acid dehydrogenase. Branch chain alpha keto acid dehydrogenase. If this enzyme is not there, the branch chain will not be metabolized, and in the urine, in the sweat and the stool, a very peculiar smell like a maple syrup, pancake syrup, burnt sugar smell will be there. That is called as maple syrup urine disease. And in the maple syrup urine disease, they ask a question. We know the name of the enzyme. It is branch chain alpha keto acid dehydrogenase deficiency leading to maple syrup urine disease. But which is the most important reaction which is defective? The most important reaction which is defective, it is oxidative decarboxylation. Oxidative decarboxylation. So maple syrup urine disease, 2 points to be remembered. 2 points to be remembered. 1. Which enzyme deficiency? Branch chain alpha keto acid dehydrogenase. And the which reaction is going to be defective? Oxidative decarboxylation. Oxidative decarboxylation. Done. Coming to hyperhomocystinemia. This was your last exam question. Hyperhomocystinemia. Increased level of homocysteine in the blood. Hyperhomocystinemia. Increased level of homocysteine in the blood. Hyperhomocystinemia. Right? Hyperhomocystinemia. Why? What are the causes of hyperhomocystinemia? These are the 3 causes. Cystathioin beta synthase deficiency, B12 deficiency and B9 deficiency. Which is the most common cause? This was your exam question. Why the homocysteine amino acid increases? The most common is cystathione beta synthase deficiency. Cystathione beta synthase deficiency leads to increase in the homocysteine. Why we are so much worried about homocysteine? It's an amino acid. Why we are worried? Homocysteine is a very bad amino acid. If it increases, it leads to thickening of the blood. It leads to atherosclerosis. So those who are having more homocysteine, there is a chance that their blood becomes very thick. There is going to be deep vein thrombosis. There is going to be atherosclerosis. The patient can develop coronary artery disease. So they ask this question: hyperhomocystinemia. What is the most common cause? Cystathione beta synthase deficiency. How you are going to identify? How you are going to identify? See, 1. The body features. The patient of homocysteine, hyperhomocysteine will have a very peculiar body feature. He is going to be having tall, his fingers will be long cylindrical, that is archinodactyly, the arm length will be more, the ectopia lentis will be there, the sole will be flat, sternum deformity, scoliosis, these are the things will be there. You must be wondering that all these things are there in the Marfan syndrome also. Marfan syndrome and homocystinuria, the body features are same. Then how to differentiate Marfan syndrome from homocystinuria? In homocystinuria, there is a risk of DVT, and in homocystinuria, there is IQ is sometimes also less. So whenever you see that a patient is having Marfanoid habitus looking like these symptoms, these features, 2 possibility, Marfan or homocysteine. If they say in the MCQ DVT or thrombus formation, dementia, DVT, stroke, hypercoagulability, if these things are written, it is homocysteine. If it is homocysteine. And what is the most common cause of increased homocysteine? Cystathionine beta synthase deficiency. Cystathionine beta synthase deficiency. Right? Now coming to the next, cystinuria. What is cystinuria? It's very simple. Diabasic amino acid is coming in the urine is called as cystinuria. What is diabasic amino acid? Simple mnemonic, cola. Cola is coming in the urine, cystinuria. Cola is coming in the urine, cystinuria. What is cola? Cysteine, ornithine, lysine, arginine. If they are coming in the urine, it is called as cystinuria. Problem with this is these molecules, these amino acid makes the crystal and they deposit in the renal pelvis and they develop the renal stone. So the patient will develop severe flank pain, nausea and vomiting. So how the cystinuria patient will present to you? As a patient of renal stone. What are the questions they will ask? Two questions. If a patient is coming with the kidney stone and in the urine there were diabasic amino acid is there, most likely diagnosis cystinuria. And what are the diabasic amino acid? Cysteine, ornithine, lysine and arginine. Right? This is the patient will present with the flank pain, nausea, vomiting. This is called as the cystinuria. Let's move forward. Coming to the next amino acid, arginine. Arginine. From arginine, we make a molecule, nitric oxide. Nitric oxide is a very potent vasodilator. It is synthesized in the endothelial cells and that leads to generation of cyclic GMP and that leads to vasodilation. What is the meaning of this? See, when you were there, be it Kyrgyzstan, Russia or whatever it is, Kazakhstan, wherever you were, when the temperature was less and when you were coming from your bus stop to your hostel or to your flat, you were wearing the jacket but you are not wearing the gloves. You have noticed that when you come, you are having the heavy glossy bags in your hand and when you will coming, the winter exposure, because of the winter exposure in your hand becomes very pale. But within no time, your hand returns back to normal color, light pinkish. How? The vasoconstriction, whenever happens in our body, the vasoconstriction can convert into vasodilation immediately with the help of nitric oxide. And who is doing that? Endothelial cells. But if someone is having defect in the endothelial cells, for example, if there is a person who is having defect in the endothelial cells and there is a winter exposure happens to the chest we have the coronary artery. If there is a spasm in the coronary artery, you and me, if we go into the winter, there is no problem. But this patient, because the endothelial cells are not working, the vasospasm will occur, but the vasodilation will not occur. So what I am saying is, if there is a defect in the endothelial cell, there is decrease in the nitric oxide and the reflux vasodilation will not occur. And if this happens in the coronary artery, the patient will have the chest pain and this is called as what? Prince metal angina. This is called as Prince metal angina or this is also called as vasospastic angina. Called as vasospastic angina. Prince metal angina or vasospastic angina. Done? So what is Prince metal angina? Defect in the endothelial cell. How you are going to pick the MCQ? If they say winter exposure leading to chest pain, recurrent chest pain, whenever winter exposure, chest pain, Prince metal angina. Winter exposure, chest pain, Prince metal angina. What is the ECG finding? In the ECG, we are going to have the ST elevations. ST elevation does not occur only in MI. ST elevation is also there in Prince metal angina. What is the treatment? Because the problem is vasoconstriction, so you will give the vasodilators such as nitrates or you can give the CCBs. We need to give the nitrates or the CCBs. This is the treatment that we are going to give to the patient. And so, what we have discussed about arginine, 4 questions to be remembered, only 4 points. Arginine. Arginine, what is the special product you are going to make from arginine? Nitric oxide. What is the secondary messenger of nitric oxide? Question from physiology. Secondary messenger, cyclic GMP. If there is a defect in the endothelial cells, because of that, winter exposure, recurrent chest pain, winter exposure, recurrent chest pain, Prince metal angina. ECG finding, ST elevation. Drug of choice, nitrates. Or you can give CCBs. Done. This is all about the chapter of amino acid. All about the chapter of amino. Coming to the collagens. So, we have different types of collagen, almost 20 types of collagen we have. The type 1 collagen, which is found in the bone and sclera, mainly bone, ligament, tendon, sclera. If the type 1 collagen is defective, means the bones will be defective. That is called as osteogenesis imperfecta. So there is going to be multiple fractures. There is going to be sclera will become very thin. So there is going to be blue sclera. There is going to be hearing problem also. So osteogenesis imperfecta, 3 symptoms. The important is two. There's going to be multiple fractures and there's going to be blue sclera. The moment you see blue sclera, multiple fracture, it is osteogenesis imperfecta. If there is a defect in type 2 collagen is found in the cartilage. The cartilage will be defective and that is called as chondrodysplasia. If the type 2 is defective, that is called as chondrodysplasia. If the type 4 collagen is defective, that is called as Alport syndrome. If the type 4 collagen is defective, that is called as Alport syndrome. Alport syndrome. In Alport syndrome, there is a classical triad. What is the classical triad? Hematuria, SNHL, and anterior lenticonus. As SNHL, hematuria, and anterior lenticonus, this is a classical triad of Alport syndrome. What is the problem? The type 4 collagen is defective. Alport syndrome should not be confused with the Goodpasture syndrome. See, in Alport syndrome, the type 4 collagen itself is defective. It is Alport. And what is Goodpasture? In Goodpasture, the type 4 collagen was normal, but the immune system has made a wrong antibody and attacking the type 4 collagen in the lungs and the kidney. So the patient is developing hemoptysis and hematuria. That is called as Goodpasture syndrome. So Alport syndrome, the type 4 collagen itself defective, Alport. If the type 4 collagen was normal, there is a wrong antibody which is destroying the type 4 collagen, Goodpasture syndrome. Goodpasture syndrome. Done. Next, coming to the scurvy. See, scurvy is due to deficiency of vitamin C. Why we are discussing it here? The reason is to make the collagen, we require vitamin C. And in the collagen synthesis, there is a reaction which requires the vitamin C, that is the hydroxylation. During the hydroxylation, we require the vitamin C. If the vitamin C is not there, the hydroxylation will not happen and the collagen will be made. They are going to be defective, particularly the blood vessels. They are going to be very fragile. If the hydroxylation process will not occur, the collagens are going to be very fragile. Before I go into scurvy, I will add one point here. They ask like this: which is the most common amino acid in collagen? The most common amino acid in collagen is glycine. And if they ask that, what are the three common amino acids? Three common amino acid is found in the collagen. It is glycine, proline, and lysine. These are the three common amino acids. There was one question in your exam that which is the most common protein of the body? The most common protein of the body is collagen. The most common protein of the body is collagen. So, regarding collagen, 3 points. The most common amino acid in collagen, glycine. What are the three common amino acids? Glycine, proline, lysine. Which is the most common protein? Collagen. During the collagen synthesis, we require vitamin C for hydroxylation. If the vitamin C is not there, the hydroxylation of these amino acids, the proline, lysine will not happen and the collagen will be very defective, particularly the blood vessels. They will be very fragile. With a small trivial trauma, they will rupture. So, there was a boy, Golu, 10-year-old, and he was belonging to poor socioeconomic status. He was not having the access to vitamin C, citrus fruits, Indian gooseberry, amla, not access. So vitamin C deficiency. Because of that, the collagen was faulty. One day he was playing in the street and he had a small trauma, blunt trauma on the left lower limb. Because of this, what happened was one of the blood vessels in that area has ruptured. You know that the cover of the bone is called as the periosteum, and the periosteum is the only structure which is pain sensitive. So now what happens is one of the blood vessel ruptures. Because of that, the bleeding happened and there was a stretch in the periosteum. So he had severe pain. He came back home. He was sitting in the corner. He was crying. The mother came. What happened? The child said, there is a pain in my lower limb. The mother was trying to examine. The child not allowed, because what is happening? The moment you move the limb of this child, there is going to be more pain. The child has understood that if I move the limb, there is going to be more pain. He will stop moving the limb as if there is a paralysis. So this is called as what? This is called as pseudoparalysis. This is called as pseudoparalysis. Pseudoparalysis is seen where? Scurvy. What are the other things that will be there? When this patient will come to you, you will see that there are multiple areas where the bleedings are happening. There can be parafollicular bleeds, means in the hair follicles, there will be bleeding. So you can see the red spots. There can be gum bleeding. And you will make a diagnosis that, okay, it is going towards scurvy. Let's add an important MCQ from radiology. If you do the chest X-ray of this patient, what are the findings you are going to get? You are going to get the Wimberger's ring. You are going to get the white line of Frankel. And just below that, the black color zone is the Sommerfeld zone. These are the important questions from the scurvy. So, why we have discussed scurvy here? Why we have discussed it? Because collagen. Vitamin C is not there. Which process will not happen? Hydroxylation of the collagen will not happen, and the collagen will be defective. Let's move on. Coming to the next chapter, that is dietary fiber. Dietary fibers. Dietary fibers are the complex carbohydrates which cannot be digested by humans. If you eat fibers, these fibers will go, and these fibers cannot be metabolized. They will come as it is in the stool. These are the complex carbohydrates. These are also called as non-starch polysaccharide. Remember this name, important. Dietary fibers, they are complex carbohydrate. They are also called as non-starch polysaccharide. There are two types of dietary fiber, water soluble and water insoluble. Mucin, pectin, gum, these are water soluble. Water insoluble, cellulose, hemicellulose and lignin. Now what happens is, we know that dietary fiber is not digested, but if the dietary fiber remains in the colon for a long time, the commensal bacteria, the good bacteria of the intestine can ferment them. They can't digest dietary fiber, but the commensal bacteria can ferment them. There is one dietary fiber which is neither digested nor fermented. What is the name of that? Can you tell me? Yes, what is the name of that? Lignin. Lignin is a dietary fiber which is neither digested nor fermented. Neither digested nor fermented, right? So, what are the questions to be remembered from dietary fiber? These are the complex carbohydrate, non-starch polysaccharide, two types. Water soluble, water insoluble. Because it's a combination of three, potential all except question. Mucin, pectin, gum, water soluble. Cellulose, hemicellulose, lignin, water insoluble. There is one dietary fiber which is neither digested nor fermented, lignin. And every day, one should eat how much dietary fiber? The recommended daily allowance, 40 grams. Every day you should eat at least 40 grams of the dietary fiber. Done. Now coming to the glucose transporters. It's a straightforward. I want you to remember few points regarding GLUT only. The glucose transporter. GLUT1 is found in the RBC. It's found in the RBC, and RBC is everywhere. So this GLUT1 is also called as widely distributed GLUT. Also called as widely distributed GLUT. It's also called as widely distributed GLUT. Right? Very good. The GLUT2, it is found in the beta cells of the pancreas. GLUT3 is not important. GLUT4, it is insulin sensitive. It is found at three places: cardiac muscle, skeletal muscle, adipose tissue. So, what are the points to be remembered so far? GLUT, which is widely distributed, GLUT1. Beta cells of the pancreas, GLUT2. GLUT4 is insulin sensitive, found at three places: skeletal muscle, cardiac muscle, and adipose tissue. These are the points to remember. When it comes to SGLT, sodium dependent glucose transporters, there are two: SGLT1, SGLT2. SGLT1, it is found in the intestine. Whatever glucose you are eating in your intestine, that glucose molecules are getting absorbed along with the help of SGLT1. The glucose molecules absorb with the help of SGLT1. The glucose alone is not absorbed, always it is absorbed with the help of sodium. So that is why it is called as SGLT1. So right now there are two places where the glucose absorption is happening. One is the intestine with the help of SGLT1, and second, very important, in the nephrons. In the nephrons, whatever glucose is getting filtered, this glucose is getting absorbed back with the help of SGLT2. SGLT2. But in a patient of diabetes, we don't want this glucose to be absorbed back. We want the glucose to be thrown out from the body. So what we will do, we will give a drug that is going to inhibit this channel. That is SGLT2 blocker. The name of that drug, gliflozins, canagliflozin, empagliflozin. If you block this channel, the glucose will go out from the body. If the glucose will go out from the body, it's very good for diabetes. But the problem is the urine will become very sticky and there is a chance of infection. So what is the side effect of SGLT2 inhibitor? UTI. UTI. Right? Let's go forward. Coming to glycolysis. First, let's understand the basic concept of glycolysis. What we are doing in glycolysis is, we'll start from the glucose molecule. We'll go all the way till pyruvate. In this process, there are total 10 steps. Out of 10 steps, 7 steps are reversible, 3 steps are irreversible. This process is going to occur in cytoplasm. Do you know that this is the only reaction in the cytoplasm which can generate the energy? And why the nature has made like this? See, The powerhouse of the cell is mitochondria. In our body, whatever ATPs we are generating from the mitochondria. But RBC does not have the mitochondria. How the RBC is getting the energy? RBC के लिए there is only one energy source, and that is glycolysis. That is glycolysis. So only energy, only pathway which is occurring in the cytoplasm and generates the energy, glycolysis. Total how many steps? 10 steps. How many reversible? 7. How many irreversible? 3. Now, we'll start from the glucose molecule. It is 6 carbon. We'll convert into pyruvate, 3 carbon. So basically, ultimately, we are going to get how many pyruvate? 2 pyruvates. We are going to get 2 pyruvates. We are going to get 2 pyruvates. Done. So here is the glucose molecule. We will do all these 10 reactions. Not the time cram this data. I will tell you what to remember. Glucose converts into pyruvate. There are total 10 steps. And what are the points to be remembered in this glycolysis? Come, see, the most important point. There is one enzyme in the glycolysis which is inhibited by a toxin. That name of the toxin is sodium fluoride, or in the MCQ it will write as fluorides. Sodium fluoride or the fluoride inhibits which enzyme of glycolysis? Enolase. Very important. Sodium fluoride or fluorides will inhibit the enolase. What is the rate limiting step of glycolysis? Phosphofructokinase, PFK1. How much energy we are going to generate from glycolysis? 7 ATP. So, glycolysis occurs where? Cytoplasm. Rate limiting enzyme? PFK1. Sodium fluoride inhibits which enzyme? Enolase. Enolase. Coming to the regulation, and this is now the hot favorite topic. This is what they ask. That what is the effect of insulin on glycolysis? What is the effect of glucagon on glycolysis? It's very simple. You don't have to cram this thing. See here. What is happening in glycolysis is glucose is cut down, and what we are making? Pyruvate. Insulin wants to increase the glucose level or decrease the glucose level? Insulin wants to decrease. So what is happening here? You are cutting the glucose. This is what the insulin wants. Insulin wants to cut the glucose. Insulin wants to decrease the glucose level. So insulin is going to stimulate this process. Insulin wants to decrease the glucose, and opposite is glucagon. Glucagon never wants to cut the glucose. So glucagon is going to inhibit the enzymes of glycolysis. Glucagon will stop. No, we don't want to happen that, right? So insulin is going to stimulate. Glucagon is going to inhibit. Glucagon is going to inhibit. Done. Now see here, what is happening here is we start from the glucose molecule, we come all the way till pyruvate, that is glycolysis. What to do with this pyruvate? It will depend whether the oxygen is there or not there. If the oxygen is not there, means the anaerobic pathway. In the anaerobic pathway, the pyruvate will convert into lactic acid. And in that process, we require some energy. And this is called as anaerobic glycolysis. So in the anaerobic glycolysis, the net energy gain is just going to be 2 ATP. In the glycolysis, we have conserved 7 ATPs. But if you do this last step, anaerobic, you will lose 5 ATPs. So the net gain is just going to be 2 ATPs. So glycolysis, how much ATP? 7. Anaerobic glycolysis, 2. If the oxygen is available, the pyruvate will go inside the mitochondria. And in the mitochondria, this pyruvate will convert into acetyl-CoA. That acetyl-CoA can run the TCA cycle. So now what we are going to discuss is the pyruvate converts into acetyl-CoA. Pyruvate can convert into acetyl-CoA, and that can run the TCA cycle. That can run the TCA cycle. So now our primary focus is going to be the TCA cycle. How it is happening? So what we are making a background that from where the TCA cycle is coming. I could have started the TCA cycle all of a sudden. You may not have linked the thing. So what is TCA cycle, from where it is coming? Glucose, when you break down pyruvate. Pyruvate, if the oxygen is not there, convert into lactic acid. Will give you how much ATP? 2. Oxygen is there, it will convert into acetyl-CoA, which will run which cycle? TCA cycle. Now let's see the TCA cycle. So TCA cycle is going to occur where? This was your exam MCQ. Going to occur in the mitochondria. Going to occur in the mitochondria. Right? So this is the Krebs cycle. This is the Krebs cycle. We are starting with the acetyl-CoA molecule. We are starting with the acetyl-CoA molecule, and we are doing all this stuff. Not important. What is to be remembered? This pathway? No. What is to be remembered? Where we are doing it? Mitochondria. If you do this, how much ATP you are going to get? 10 ATPs. 10 ATPs. How much you are going to get from Krebs cycle? 10 ATPs. There is an inhibitor which can inhibit the Krebs cycle, and the most important, only one I want you to remember, that is fluoroacetate. Sorry, the malonate. Malonate is going to inhibit which enzyme? Succinate dehydrogenase. Malonate is going to inhibit which enzyme? Succinate dehydrogenase. So, what are the points to be remembered? Krebs cycle occurs where? Occurs where? Mitochondria. How much ATP Krebs cycle? 10 ATPs. There is one toxin which can inhibit the Krebs cycle, the important one, malonate. It inhibits which enzyme? Succinate dehydrogenase. Succinate dehydrogenase. Now, you know that in our body, the energy is synthesized in three forms: NADH, FADH, ATP. Whenever you are generating the energy directly in the form of ATP, that reaction is called as substrate level phosphorylation. Again, repeating. Whenever you are generating the energy directly in the form of ATP, that is called as substrate level phosphorylation. In the Krebs cycle, only one time it happens, and that is the enzyme is succinyl thiokinase. Succinyl thiokinase. So substrate level phosphorylation in the Krebs cycle, it occurs only once, and that is, what is the name of enzyme? Succinyl thiokinase. Succinyl thiokinase. Done. Okay. Thank you. Thank you for all the comments. Let's move forward. What we have discussed so far. I'm just imitating the 5 important MCQ from Krebs cycle. Krebs cycle occurs where? Mitochondria. How much ATP? 10 ATP. What is the inhibitor of Krebs cycle? One of the inhibitor, malonate. It inhibits which? Succinate dehydrogenase. There is one reaction where the substrate level phosphorylation occurs, and the name of that is succinyl thiokinase. And what is the substrate for that? It is succinyl CoA. Succinyl CoA. Then coming to glycogen. Very important concept. Very high yield. Definitely there will be one question on 20th of January, what we are going to discuss in next around 5 to 10 minutes. Everyone, very attentive. Next 5 to 10 minutes. See, first let's understand what is glycogen is. When you take a lot of extra meal, particularly if you remember when you were in the hostel, in the flat, right, we were not just eating, we were eating till esophagus. Sometimes we are feeling till esophagus. Now, if you eat this much, what is going to happen? A lot of extra glucose is going to be absorbed. This will come here in the liver. Liver will say that, okay, what to do with this extra glucose? So liver will say that, okay, these extra glucose will club these extra glucose molecule. Liver is going to club these extra glucose molecule. The molecule that is going to be synthesized is called as glycogen, and that will be stored there. Why the liver is storing? Liver is thinking that someday this guy will become hungry, he will be in the fasting state, will break this glycogen and will give the glucogen back to this, so we will get the energy at that time. So the liver has stored the glycogen, and once the liver storage is full, still there is more glucose. Where to store? The liver will request muscles that please you also store some glycogen. So some of the glycogen will be stored there. So the glycogen is stored at two places. One is the muscle, second liver. This is the basic concept behind glycogen. And when we don't take the meal, this glycogen will cut down, and what we are going to get back? We are going to get back the glucose. So there are two processes. Glycogen synthesis, that is called as glycogenesis. It occurs during the well-fed state. And the glycogen breakdown, which is called as glycogenolysis, it occurs during which state? Fasting state. It occurs during fasting state. Let's see how this process is happening. First, we are talking about glycogenesis, how the glycogen synthesis is happening. Whatever extra glucose you are having, that extra glucose molecule will convert into a molecule glucose 1-phosphate, then glucose 6-phosphate, and ultimately they are going to make the glycogen. This process is called as glycogenesis. It is occurring where? Liver. And when it is occurring? Well-fed state. When you are in the fasting state, now it's the important part. See, when you are in the fasting state, when you are not taking the meal, the glycogen will cut down, and it will cut down in two organs. What are the two organs? Liver and muscle. It is going to cut down in two organs, liver and muscle. When we cut down the glycogen, there are several enzymes are used in that pathway. When you cut down, you will generate glucose 1-phosphate, converts into glucose 6-phosphate, and that can convert into glucose. And this is what we wanted. And this glucose will come in the blood and will maintain your glucose level. You must be knowing that, right? Ki Even if we don't take a meal for 8 hours, we'll not go into hypoglycemia. One of the reasons is this pathway, right? Because the glycogen which we are having, it will cut down, we will get the glucose and will not go into hypoglycemia. But now the tricky point. This process, glycogenolysis, is occurring at two organs, liver and muscle. You see the last enzyme, which I have highlighted with the green color, glucose 6 phosphatase, it is only found in the liver. The meaning of the enzyme was there in the liver and muscle. There was no problem. The problem with this enzyme is only there in the liver. So if I ask you, answer me, what is the last product of glycogenolysis in the skeletal muscle? In the skeletal muscle, what will the last product? Glucose 6 phosphate. What is the last product in the liver? Glucose. And this is how the cutting happens. But by chance, this is the entire the glycogen metabolism. If you see this pathway, there is only one enzyme which is common in both the pathway, glycogen synthesis as well as glycogen breakdown. There is only one enzyme which is common in both the pathway, phosphoglucomutase. Important MCU. Phosphoglucomutase. Phosphoglucomutase is the only enzyme which is common in both the pathway, glycogenesis as well as glycogenolysis, common in both the pathway. Done. Now, if there is problem with any of the enzyme, the glycogen breakdown will not occur properly. Glycogen breakdown will not occur properly, and these are called as the glycogen storage diseases. These are called as the glycogen storage disease. You must have heard the mnemonic ABCD, the Anderson branching enzyme, Cori debranching. Out of that glycogen storage disease, the most common glycogen storage disease, it is von Gierke disease. Von Gierke disease. So we are going to discuss von Gierke disease that occurs in the pediatric age group. That is overall most common. But if you ask me that, which is the most common glycogen storage disease in adults, particularly adults, then it is McArdle's type 5, McArdle's disease. So we need to understand these two diseases in detail, von Gierke and McArdle's. First, let's talk about von Gierke. Now, von Gierke is due to deficiency of enzyme that is glucose 6 phosphatase. Let's understand a basic concept. See, glucose 6 phosphatase is found in the liver, and here is the enzyme in the pathway, glucose 6 phosphatase. Glucose 6 phosphatase. If this enzyme is not there, the glucose 6 phosphate will not convert into glucose. Means what? For example, there is a 3-year-old boy. What happened was, his mother was working at a construction site as a laborer. And what happened was, the mother forgot to give him meal to the child. The child was playing there and there. The child has not got the meal. So what the liver will do is, because now the child is in the fasting state, the liver will cut the glycogen. When you cut the glycogen in the fasting state, you will get glucose 1 phosphate, you will get the glucose 6 phosphate. You could have converted into glucose. For that, which enzyme is required? Glucose 6 phosphatase. But this child is not having this enzyme. There is deficiency. There is deficiency of this enzyme. This reaction will not happen. The glucose will be less. The child will go into hypoglycemia, and the symptoms of hypoglycemia will appear in the child. Sweating, palpitation, the child may go into syncope. If the sugar is very less, the child may have seizure. Because this child is having most of the time less blood sugar, so he might be having decrease in the growth also. So this child will develop hypoglycemic symptom. Von Gierke disease, how to diagnose? If they say that there is a child, whenever he skips a meal, he go into hypoglycemia, it is von Gierke. What are the additional things? This is what they have asked, and they can ask. See, now everyone pay attention. If this reaction will not happen, there is going to be increase in glucose 6 phosphate. There is going to be increase in glucose 6 phosphate. The problem with the glucose 6 phosphate, it is impermeable to cell membrane. Because it is impermeable to cell membrane, slowly it will build up in the liver, and the liver size will increase drastically. This child will have hepatomegaly. There is one more thing. This glucose 6 phosphate can convert into lipids and uric acid. So this child will have increase in the uric acid, increase in the lipid, hyperlipidemia, hyperuricemia. What are the points to be remembered from this disease? First, von Gierke disease due to deficiency of which enzyme? Glucose 6 phosphatase. What happens with the glucose level? Less. What the two things are going to increase? Lipid and uric acid. Hyperlipidemia, hyperuricemia, but the glucose is less, hypoglycemia. This disease only affects the liver, because this enzyme is physiologically not there in the muscle. So this disease is not going to affect muscle anyhow. It's only going to affect the liver, because this enzyme is found in the liver only. If it is not there, it is going to affect it is going to affect the liver only, right? So this is how the von GRK patient is going to present to you. Done. Now coming to McArdle's disease. McArdle's disease is the type 5 glycogen storage disease. Type 5 glycogen storage disease. This is the most common glycogen storage disease in the adults. It is due to deficiency of enzyme muscle glycogen phosphorylase. McArdle's, M for McArdle, it is due to deficiency of muscle glycogen phosphorylase. See here how the patient is going to present. Let's say, for example, there is a boy, Rakesh. Rakesh has taken the admission in one of the foreign medical university. Right now, he is just 12 pass. He is 18-year-old and he has cleared his NEET exam. He has taken the admission and he is supposed to travel 3 months after that. So he decided to go to the gym before going to the college. He decided to, and he's going to the gym for the first time. So he got up at morning 6 a.m. He went to the gym for the first time in his life, and when he goes there, he took out the heaviest पत्थर, सबसे भारी पत्थर लेता है और वहाँ पे उठाने लग जाता है. He start doing the exercise with the heaviest weight. Now, what is going to happen is the muscle requires energy. See, you and me, if we do that, there's no problem, because when the muscle requires ATP, in the muscle we have glycogen, and we will cut the glycogen, we'll get the glucose 1 phosphate, glucose 6 phosphate, and that will go into glycolysis, and ultimately we will get the ATPs. So you and me will not have any problem if we do physical exertion. But the problem with Rakesh is not having this enzyme, muscle glycogen phosphorylase. If this enzyme is not there, this reaction will not happen. So when he go to the exercise, now everyone pay attention. What is going to happen? What is going to happen is that when he is going to lift the weight, within next 5 to 10 minutes, this reaction will not happen. So there is going to be decrease in glucose 1,6 phosphate, and ultimately there is no ATP. The muscle cell will die. They will rupture, and Rakesh will feel severe pain. The muscles will rupture. He will feel severe pain. Because of the muscles are rupturing, so there is a protein in the muscle, myoglobin. It will come out, and this myoglobin via the blood will go to the kidneys, and they will block the kidney tubules. After a couple of hours, he will have pain in the kidney area. He will have pain in the flank area. Earlier, he was having pain in the muscles. Now, he will have pain in the flank area. When he will go to urinate, because of acute tubular necrosis, he will have the dark urine. So, how to diagnose McArdle's? If they say that there is a guy, whenever he do physical exertion, he is having severe muscle pain, followed by pain in the flank area, followed by dark colored urine, McArdle's. What is the enzyme deficiency? Muscle glycogen phosphorylase. And it's a tricky question. If they want to ask a difficult question, can you tell me what is the coenzyme for muscle glycogen phosphorylase? What is the coenzyme for muscle glycogen phosphorylase? Can you tell me the coenzyme for muscle glycogen phosphorylase? Can you tell me the coenzyme for muscle glycogen phosphorylase? Yes, very good. The good doctor, it is vitamin B6. Means what? For the treatment of Rakesh, we can give vitamin B6. We've seen that if we give vitamin B6, to some extent, the patient will feel better because this enzyme will start working better. Okay, this is all about the glycogen storage disease. Now let's come to the next molecule, that is galactose. How the galactose is metabolized. First, let's understand where the galactose is found. Very good. First, let's see where the galactose is found. Galactose is found in the milk. In the milk, we have the milk sugar called as lactose. When you drink milk, the lactose goes in your intestine. In the intestine, we have an enzyme called as lactase, which will break the lactose into two, galactose and glucose. See here, there was a child, just a newborn. The mother was breastfeeding. In the breast milk, there was lactose. The lactose was going inside the intestine. In the intestine, we have the enzyme lactase. It will split the lactose into two, glucose and galactose. Right now, our concern is galactose. This galactose will get absorbed, and this galactose will get absorbed. It will go all the way to the liver. In the liver, the galactose metabolism happens, and there are several enzymes are involved in that. And ultimately, the galactose will convert into glycogen. It will help in the glycogen synthesis. But now the tricky part, everyone see here, for the galactose metabolism, we require one enzyme, that is galactose 1-phosphate uridyl transferase. I will tell you how to remember that in a while. There was a child, the problem with the child was this enzyme was not there. Uridyl transferase was not there. So what is going to happen when the mother is going to breastfeed? The molecule that will accumulate in the liver is going to be the galactose 1 phosphate, because it is unable to metabolize forward. The problem is it is impermeable to cell membrane. It will accumulate in the liver, so there is going to be increase in the size of the liver. And because the galactose is not getting metabolized, so the galactose will also increase, and this galactose will come in the blood also. It will convert into calcititol and it can deposit in the lens of the eye, and the patient will develop the oil drop cataract. It's also seen that those who are having galactosemia, there is increased risk infection of E. coli. So, what are the points to be remembered? First, let's understand how to make diagnosis. If they say breast milk followed by vomiting, in a newborn, galactosemia. Which is the enzyme deficiency? Uridyl transferase. Second, what are the things that will be there? There is going to be hepatomegaly, there is damage in the liver, so jaundice, oil drop cataract, E. coli infection, decrease in the IQ, all these things will be there. So it's very easy to diagnose. Breast milk followed by vomiting, galactosemia, the enzyme deficiency is uridyl transferase, the patient will have jaundice, decreased IQ, oil drop cataract. Oil drop cataract is due to calcititol. Done. Next, if you, very good, Gelput, very good. Next is fructose. When you take the fruits, when you eat fruit or you take the fruit juice, the fructose absorbed in the intestine reaches to your liver and the fructose will be metabolized. In the fructose metabolism, we have different enzymes are there. The key enzyme for the fructose metabolism is aldolase B. If this aldolase B is not there, the fructose metabolism will not occur and the fructose 1 phosphate will accumulate in the liver, which is impermeable to the liver, and the patient will develop the nausea and vomiting. So if they say that the patient, whenever the patient is taking fruit juice, after taking the fruit juice, the patient is having nausea, vomiting, abdominal pain, it is going towards fructose intolerance. And what is the name of the enzyme? Aldolase B. So after taking the fruits, the patient is having the problem, fructose intolerance. So this is one of the mnemonic to remember the galactosemia and fructose intolerance. Fructose intolerance is due to deficiency of aldolase B. Galactosemia is due to deficiency of uridyl transferase. We will remember the mnemonic FABGUT. Fructose intolerance is due to aldolase B. Galactosemia is due to deficiency of uridyl transferase. Galactosemia is due to deficiency of uridyl transferase. Right? These are the points to be remembered for the galactosemia and the fructose intolerance. Done. We'll just take a short break of 5 minutes, and it's just 1 and 15 minutes we had, but as I was having a class since morning, so just we'll take a 5 minute and we'll come back. Just 5 minutes. Okay, the next disease we are discussing is Gaucher disease. What is Gaucher disease is the glucocerebrocytes which we are having in our body. These glucocerebrocytes are metabolized by the enzyme beta glucocerebrosidase. Now, sometimes what happens is this enzyme is not there. If this enzyme is not there, the beta glucocerebrocytes will not be metabolized. Particularly the glucocerebrocytes will not be metabolized and they are going to increase. And once they will increase, they are going to deposit at different places. Some of them will deposit in the liver, some will deposit in the spleen, some will deposit in the bone marrow. Now, because this glucocerebrocyte will deposit it in the different parts, there is going to be hepatomegaly, splenomegaly, and because the bone marrow they are getting stored, so the bone marrow will not work properly, and there is going to be decrease in the hemoglobin, and because of that, the patient will develop anemia. So remember, language of the question. They will say 8-year-old boy, hemoglobin 6.2 means anemia, hepatosplenomegaly, and they will give this image. Will give this image. The image will be slightly different, but something like this. A cell will be there, in which the cytoplasm is very rough. The cytoplasm is very rough. Very rough. This is the crumbled tissue paper appearance of the cytoplasm. These are the things they will say you that hepatosplenomegaly, anemia, 8-year-old boy, this particular cell is there. What is the most likely diagnosis? Gaucher. But they will not ask the diagnosis. They will say that what is the enzyme deficiency that is creating this problem? The enzyme deficiency is beta glucocerebrosidase. Beta glucocerebrosidase. Problem is because of beta glucocerebrosidase. Done. Next is Fabry disease. Fabry disease is an X-linked recessive disorder and it is due to deficiency of alpha galactocerebrosidase. And the most important hallmark is angiokeratoma. If you see this word angiokeratoma, it is Fabry disease. Anywhere, if you see angiokeratoma, Fabry disease. Fabry disease is due to deficiency of alpha galactocerebrosidase. Alpha galactocerebrosidase. Okay. The next is, let's understand the various lipid disorders. Lipid disorders. See, when you go to eat pizza, what happens is a lot of triglyceride you are eating. You are eating a lot of fat. These exogenous triglycerides molecules get absorbed in the intestine, and these from the intestine, someone has to take this exogenous triglyceride molecule to the liver. And who is going to do that? Chylomicron. Chylomicron, when it go towards the liver, in between, it will give the triglyceride to the tissues also. And to give the triglyceride to tissue, it requires the enzyme lipoprotein lipase. Just imagine if this enzyme is not working, lipoprotein lipase. What is going to happen? The chylomicron will not utilize and they are going to increase. And it's an autosomal recessive disorder. And in this autosomal recessive disorder, the chylomicrons are increasing. So the name of this disease is called as type 1 lipid disorder. It is also called as familial hyperchylomicronemia. Familial hyperchylomicronemia. What is the problem in familial hyperchylomicronemia? Lipoprotein lipase enzyme is not there. So the chylomicron is increasing. If the chylomicron increase, the triglyceride will increase. And hypertriglyceridemia will lead to pancreatitis, and this patient will present as pain abdomen. Pain abdomen. Let's say at the surgery point here that in the pancreatitis, which scoring system we use? We use the Ranson scoring. We use a score, Ranson score in pancreatitis. Right? This is the type 1 lipid disorder. Type 1 lipid disorder. Now coming to type 2A lipid disorders. Very important. Type 2A lipid disorder. Yes, rightly said Harshit. Ranson. The next is type 2A lipid disorder. See, in your liver, some amount of cholesterol is synthesized. This cholesterol is supposed to be given to the tissue where it can be utilized. And who is going to take this cholesterol from the liver? LDL. We put the cholesterol molecule in the LDL, and this LDL will go and the cholesterol will get utilized. Now, when the cholesterol is delivered, it requires some receptors. Just imagine that if these receptors are not working, the cholesterol will not be given, it will not be utilized. And if it is not utilized, the cholesterol is going to increase. And this is an autosomal dominant disorder. In all the family members, the cholesterol is not getting utilized, the cholesterol will increase significantly. And this is called as familial hypercholesterolemia. Hypercholesterolemia, excess amount of cholesterol. And this excess cholesterol will deposit in different parts of the body. The patient will have xanthelasma, tendon xanthomas. So these are the various findings will be there. So familial hypercholesterolemia, 2 points to remember. It is an autosomal dominant disorder and there is a defect in the LDL receptors. So there is all the family members will have increase in the cholesterol. Done. The next is the nucleic acids. The nucleic acid, when it comes to nucleic acid, we have the DNA and the RNA. We have the DNA and RNA. Whether you see a DNA or RNA, they are the chains of the nucleotide. So we need to understand that what is the meaning of nucleotide. Nucleotide is basically is made up of three things. It is made up of nitrogen base, pentose sugar, and the phosphate. Nitrogen base, pentose sugar, and phosphate. Nitrogen base is of two types, purines and pyrimidines. The purines we have is A and G, and the pyrimidine is CUT. Cut the pyramid. Cut the pyramid. So how to make the nucleotide? You take any of the nitrogen base, you will take any of the sugar. We have two options, deoxyribose and ribose. If you want to make a nucleotide for RNA, you will use ribose sugar. If you want to make a nucleotide for DNA, you will use deoxyribose. So you will take these three things together, you will make a nucleotide. If you make a single chain of nucleotide, that is called as RNA. If you make two chains of nucleotide, called as DNA. That is the basic difference. Now, what questions they will ask? See, how to make the nucleotide. We take a 5-carbon sugar, pentose sugar. Pentose sugar means 5 carbon. On the carbon number 1, we are going to attach the nitrogen base. On the carbon number 1, we are going to attach the nitrogen base. And on the carbon number 5, we are going to attach the phosphate. The nitrogen base and the phosphate, nitrogen base and the pentose sugar, when they unite, the bond is the glycosidic bond. And this unit is called as the nucleoside. On top of that, we are going to add the phosphate with the help of ester bond, and this entire unit is called as nucleotide. So they ask that what is the bond? The important question is what is the bond between the nitrogen base and the pentose sugar? It is the glycosidic bond. Glycosidic. Done. When it comes to the purine and pyrimidines, we are saying that the purines which we are having is A and G. So when a cell die, a lot of DNA and RNA comes out and we need to destroy them. So when you destroy them, the purines and pyrimidines will come out. We need to destroy the purines further. So how we catabolize the purine? To catabolize the purine, we have the two enzymes, HGPRTase and adenosine deaminase. The deficiency of HGPRTase will lead to a disorder called as Lesch-Nyhan syndrome. It is an X-linked recessive disorder. In this, the child will have profound mental retardation. He is going to eat out its own fingers and the toes. That is called as self-mutilation. Mental retardation, there is going to be increase in the uric acid. This is called as the Lesch-Nyhan syndrome. The second enzyme which is required for the purine catabolism is adenosine deaminase. If there is deficiency of adenosine deaminase, it will lead to SCID, severe combined immunodeficiency. Combined, why it is called combined? Because B cell and T cell both are involved. So it is called as combined. Now, if you see that when we talk about the purine catabolism, it is converted, when you destroy the purine, you get uric acid. And this uric acid could have been converted into allantoin with the help of enzyme uricase. But this uricase enzyme is physiologically not found in humans. So what is the last product technically we are making by the purine catabolism is uric acid. We are making uric acid. And this uric acid, if it is more, the crystals will be generated, they will deposit in the tissue and will lead to gout. So what is gout? Super important topic for your exam, gout. There is going to be a crystal called as monosodium urate. The monosodium urate crystals, they are going to deposit in the joints, particularly first metatarsophalangeal, means this joint, great toe, and particularly seen in the alcoholics. There is going to be severe pain. The serum uric acid level at the time of pain may be decreased or maybe increased or maybe normal. What is going to happen is the crystals which we are talking about, they are the needle shaped crystals. They are going to deposit in the first MTP. The patient will have severe pain. Most of the time, when they ask the question on gout, they are going to ask on the treatment. Last time there was also a question, I will tell you that. If they ask the drug of choice for acute attack, NSAIDs. If they say what is the chronic gout drug of choice, allopurinol. And the question that was asked was how the probenecid works. See, probenecid increases the excretion of uric acid. So basically, it's a uricosuric drug. Probenecid is a uricosuric drug. So this is how we are going to treat the gout. The DNA and the histone, they have a very tight relationship. What we do is we take the histone molecule, we turn the DNA around the histone molecule to make the DNA compact and we fit in the nucleus. DNA and histone, they are found in a very close relationship. Now what happens is they are so tightly related, the histone becomes the best friend of the DNA and the histone starts regulating the DNA. How? If you want to do any procedure, say for example, you want to do transcription. Transcription means DNA to RNA. You want to make DNA to RNA. You need to take the permission from histone. What you need to do is, if you want to activate the transcription, you need to do acetylation. A for acetylation, A for activation of the transcription. If you want to stop the transcription, you need to do the methylation. If you do the methylation, it is going to mute the transcription. It's a very important topic, very important point actually. If you do the acetylation, that will activate the transcription. If you do the methylation of histone, that is going to stop the transcription. Methylation is going to mute, acetylation is going to activate. Now, when you do the replication process, if there is during that procedure, if by chance, if any mistakes remains there, by any chance, if mistake happens, that is called as the, by any chance, if the mistake happens, how the mistake will happen? Normally, A will club with T and G will club with C. Normally, this is how it happens. But by any chance, if there is a mismatch happen and that mismatch remains in the DNA, the patient will develop a disease called as hereditary non-polyposis colon cancer. Mismatch repair defect will lead to colon cancer, that is called as HNPCC. This HNPCC is also called as Lynch syndrome. Lynch syndrome. If there is a defect in the helicase or ligase, the patient will develop Bloom syndrome. If there is a defect in the nucleotide excision repair, the patient will develop dry and pigmented skin, that is called as xeroderma pigmentosa. Xeroderma pigmentosa. Xeroderma pigmentosa, right? So mismatch repair defect will lead to HNPCC. Among them, this is the most important for your exam. If there is mismatch, it will lead to HNPCC. The MCQ, when it will come, they will just write the word HNPCC. They will not write colon cancer. They will not write the full frame. They will just write HNPCC. In their question bank, actually, when this question is there, the option is HNPCC only. Now coming to the missense mutation. What is missense mutation is? See, normally in the mRNA, if you make any change and that change is permanent, that is called as mutation. First, what is mutation? Any permanent change in the genetic information is called as mutation. Now, when you change the genetic information, ultimately what happens is, when we make the protein, the change in the amino acid sequence will happen. And because of that, there will be some symptoms. For example, let's say there is a mutation happened, and because of that, some amino acid sequence change. If the amino acid sequence is changed, that is called as missense mutation. Now, if the missense mutation is not creating any trouble, this is called as compatible missense mutation. Compatible means there is no problem, such as hemoglobin Hikari. There will be no symptom in a patient of hemoglobin Hikari. It's a completely compatible missense mutation. But if the mutation is so deadly, the patient is not able to survive. The patient will die in utero. This is called as non-compatible mutation, that is HBM. The patient of HBM cannot survive. Now, if the mutation is having some symptoms on and off, the clinical feature is on and off, that is called as partial compatible. The example is sickle cell anemia. In sickle cell anemia, what happens is, in the hemoglobin, we have 2 alpha chains and 2 beta chains. In the beta chain, at the 6th position, normally we have the glutamic acid. If it is replaced by valine, it is called as sickle cell anemia. For the sickle cell anemia, what happens is, basically this sickle cell anemia is also called as hand-foot syndrome. It's also called as hand-foot syndrome. The reason why it is called as hand-foot syndrome is, in sickle cell anemia, we have the sticky RBCs. Means whenever this patient will become dehydrated, the RBC will clump together, and that is going to block the capillaries, particularly in the fingers and the lower limb toes. So because of that, this disease is also called as the hand-foot syndrome, because this patient is going to have the pain in the hand and the foot. What is the treatment? Treatment is maintain the hydration. First, we need to maintain the hydration. We can give hydroxyurea also. Hydroxyurea. So this is how the sickle cell anemia is treated. Sickle cell anemia is treated. Okay. The next is a very important topic, electron transport chain. What is electron transport chain? See, we know that NADH and FADH is converted into ATPs, because we can consume the energy only in the form of ATP, and this process occurs via the electron transport chain. This process occurs via the electron transport chain. In the electron transport chain, actually there are two things are happening. You are converting the NADH, FADH into ATP. In fact, some amount of NADH and FADH is converting into one more molecule, that is heat, and that also occur in the electron transport chain. So there are two things are happening in the electron transport chain. You are converting the NADH, FADH into ATPs, and you are converting them into heat also. How? The first, the electron transport chain occurs on the inner mitochondrial membrane. This diagram has to be very clear with you. The outermost thing here is the cytoplasm, then these are the two membranes. So we are taking a cross section from here and we are zooming in. If we zoom in this area, you can see this is the outer mitochondrial membrane. This is the outer mitochondrial membrane. This is the inner mitochondrial membrane. In between them is the intermembrane space. So outside to the outer mitochondrial membrane, cytoplasm, and inside to the inner mitochondrial membrane, mitochondrial matrix. This diagram has to be very clear. On the inner mitochondrial membrane, in the inner mitochondrial membrane, we are having the 5 complex enzymes. There are 5 complex enzymes on the inner mitochondrial membrane. What they are going to do is the NADH and FADH will attach to them, and ultimately we are going to generate the ATP. The name of these complex enzymes are important. The name of these complex enzymes, NADH dehydrogenase, succinate Q reductase, cytochrome oxidase, cytochrome oxidase, and ATP synthase. These are the names of these 5 complex enzymes. What they are doing? They are continuously pumping the hydrogens. So the question asks, how many hydrogens is pumped by these various complex? The mnemonic is 40-42. The first complex is going to pump 4 hydrogen, second is 0, third is 4 hydrogen, and fourth will pump 2 hydrogen. And all these hydrogen which has been pumped, what they are doing is basically they are pumping the hydrogen in the intermembrane space, and all this hydrogen which is getting pumped, these hydrogen will start coming back via the complex 5, and when they will come by, they are going to generate the ATP. This is what we wanted. Now, what else they will ask is, there are certain inhibitors which can inhibit the electron transport chain, and this is one of the very important and the hot favorite question in the exam, that what are the toxins that inhibit electron transport chain. The inhibitors are rotenone, malonate, carboxyl that inhibits the complex 2, bal antimycin inhibits the complex 3, cyanide, carbon monoxide, hydrogen sulfide inhibits the 4. How I used to remember was रो मत बालक मच्छर काटा है, रो मत बालक मच्छर काटा है, रो रोटेनॉन, मत is malonate, बालक बाल, मच्छर is antimycin, काटा है cyanide, carbon monoxide and hydrogen sulfide. रो मत बालक मच्छर काटा है. Now, the one more we need to add is carboxyl is a complex 2 inhibitor. It's an important MCQ. Now, when I started this electron transport chain, I was telling you that in the electron transport chain, we are doing two things. We are converting the NADH, FADH into ATP. We can convert them into heat also. This process is called as uncoupling. When you do this process, this is called as uncoupling. There are certain molecules in our body which promotes the uncoupling. And one of them is very important, thyroid hormone, thyroxine. That is why you know that those who are having hyperthyroidism, they always feel very heat. They always are sweating because there is more heat production. And the opposite is also true. Those who are having hypothyroidism, the uncoupling is not happening, so heat production is not happening. So they have the cold intolerance. So who are the uncouplers? This was asked in your exam. What are the examples of uncouplers? When it comes to the examples of uncouplers, one is thyroxine, the 2,4-dinitrophenol, 2,4-dinitrophenol, thyroxine, these are the various uncouplers. Thyroxine is the physiological, 2,4-dinitro is the pathological. In fact, that was asked in your exam also. 2,4-dinitrophenol has been asked in your exam also, that which of the following is a pathological uncoupler of electron transport chain? Yes. So in the electron transport chain, what is the most important thing? This table. The name of the enzyme, how many hydrogen they will pump. This is we have already remembered, 40-42. And what is the inhibitor? Romat balak, machhar kata hai. And the uncouplers examples are thyroxine. This is the physiological uncoupler. Now coming to the vitamins and minerals. When it comes to the vitamin A, see, vitamin A is a fat soluble vitamin. So what happens is when you are eating fat and vitamin A is there in the diet, vitamin A and the fat will be absorbed together. They will be absorbed together. So when you are eating the vitamin A and the fat, they will be absorbed together. They will make a mixture. We have just now discussed that fat is absorbed with the help of chylomicron. And this chylomicron will take all the way the vitamin A in your liver, and in the liver they are going to stored in the itocells. They are going to be stored in the itocells. So, vitamin A, what is the source? The richest source is the halibut liver oil. Halibut liver oil. If there is a deficiency of vitamin A, the patient will have the night blindness, follicular hyperplasia. There can be white foamy conjunctiva, that is the bitter spot. Bitter spot. So, vitamin A, it is stored in the itocells of the liver, which is also called as the perisinusoidal stellate cell. Deficiency can lead to night blindness and bitter spot, and as well as the acne. Coming to the next vitamin, that is vitamin D. Vitamin D. Vitamin D is the one of the vitamin which we are synthesizing in the body. How? When you are sitting in the sunlight, the UV rays will fall on your skin. It will go to the adipose tissue. We have the cholesterol there. This cholesterol will convert into, with the help of UV rays, it will convert into cholecalciferol. This cholecalciferol will go to the liver, and in the liver we have one enzyme called as 25-hydroxylase. The 25-hydroxylase will convert the cholecalciferol into 25-hydroxy vitamin D. This is the storage form of the vitamin D, which is also called as calcidiol. And as and when required, this 25-hydroxy vitamin D will go to the liver, and via 1-alpha hydroxylase, it will convert into 1,25-dihydroxy vitamin D. That is also called as calcitriol. This calcitriol is the most active form of vitamin D. So the most common form that is found, calcidiol. The most active form, calcitriol. Calcitriol. And what is the rate limiting enzyme for vitamin D synthesis? 1-alpha hydroxylase. 1-alpha hydroxylase. 1-alpha hydroxylase should not be confused with 7-alpha hydroxylase. 7-alpha hydroxylase is the rate limiting enzyme of bile acid synthesis. In biochemistry, there is one more place where the rate limiting enzymes are very similar. For example, I am writing it here, CPS1 and CPS2. If you see CPS1, it is the rate limiting enzyme of urea cycle. CPS2, the rate limiting enzyme, is the rate limiting enzyme of pyrimidine synthesis. It's very similar. Then again, there are two more enzymes which are very similar. HMG-CoA reductase and HMG-CoA synthase. HMG-CoA reductase, it is the rate limiting step of cholesterol synthesis. And HMG-CoA synthase, it is the rate limiting step of ketone body synthesis. Ketone body synthesis. Ketone body synthesis, right? The next is the vitamin B2. Vitamin B2, which is also called as the riboflavin or the Warrenburg yellow enzyme. If there is a deficiency of vitamin B2, a very important thing to be remembered is there will be new blood vessel formation in the cornea. This is called as corneal neovascularization. Corneal neovascularization, it is seen in vitamin B2 deficiency. Corneal neovascularization. Corneal neovascularization should not be confused with retinal neovascularization. Retinal neovascularization, it is seen in diabetic retinopathy. Retinal neovascularization, it is seen in diabetic retinopathy, and corneal neovascularization is seen in vitamin B2 deficiency. What are the other things in vitamin B2 deficiency? There is going to be glossitis, there is going to be chiliosis, inflammation of the lips, inflammation of the tongue, that is going to be there, right? This is all about the vitamin B2. Let's understand the next mineral, that is copper. And in the copper, we need to understand two diseases, Wilson and Menkes disease. Very important. Wilson disease, we are expecting that a question will be there from Wilson disease. So let's understand what is Wilson is. When it comes to the Wilson disease, see what happens is when you take copper in your diet, this copper gets absorbed in the intestine with the help of ATP7A. ATP7A. This ATP7A is going to transport the copper in the liver. It's going to transport the copper in the liver, and this copper is going to unite with a protein which is already there in the liver called as apoceruloplasmin. The clubbing of the copper and the apoceruloplasmin occurs with the help of the molecule ATP7B. So ATP7B is helping the copper to club with the apoceruloplasmin, and the molecule they are going to make is the ceruloplasmin. And this ceruloplasmin will go out from the liver and can be excreted in the urine. At the same time, this ATP7B is also doing one thing, that it is allowing the copper to be exiting from the liver via the bile. So the function of ATP-B is very simple, that it wants that the copper should go out from the body, either in the form of ceruloplasmin or either directly in the bile. So ATP-7B, it is trying to eliminate the copper molecules from the liver. Now just imagine that if this ATP-7B is not working, if this is not working, if the ATP-7B is not working, these all process will not happen. The first thing, the copper will not club with apoceruloplasmin, so ceruloplasmin will not be made. So in Wilson disease, ceruloplasmin will be less. And because the copper is not able to exit from the liver, the copper is going to accumulate in the liver, and that is going to damage the hepatocytes. The patient will develop jaundice. And slowly, the hepatocytes will burst and the copper will come out. And from there, the copper will go into the different parts in the body, maybe heart, cornea, and is going to deposit in different organs. So what is going to happen is, if there is a defect in the copper ATP-7B, there is going to be decrease in the formation of ceruloplasmin, and there is going to be decrease in the excretion in the bile. Because of that, the copper will accumulate in the liver, hepatocyte, will lead to brain damage, will lead to deposition in the cornea called as KF ring. This is called as the Wilson disease. So Wilson disease, what happens with ceruloplasmin? Less. What happens with serum copper? More. The copper is going everywhere in the body. Serum copper is more. Now coming to Menke disease. Menke disease is due to defect of ATP-7A. Menke disease is due to deficiency of ATP-7A. Now what happens is, in the diet, the copper which you eat, this copper molecule is getting absorbed with the help of ATP-7A. If this ATP-7A is not there, the absorption of copper will not happen and the copper will be lost in the stool. If the copper will be lost in the stool, then what we can say is the copper in the blood will be very less. If less blood is there, less copper is there, it will go and it will club with less amount of apoceruloplasmin. So overall, the ceruloplasmin which is going to be made is less, because to make the ceruloplasmin we require copper. If the copper is not there, the ceruloplasmin will not be made. So in the Menke disease, the copper is less as well as the ceruloplasmin is also less. Ceruloplasmin is also less. Ceruloplasmin is less in Menke and Wilson both. The main difference is the serum copper, right? These are the points to be remembered from the copper. Coming to zinc, very important. Just 2 points. Zinc helps in the steroid hormone synthesis. So if there is a deficiency of zinc, the patient will have decrease in the steroid hormone synthesis, decrease in the spermatogenesis. Second, if there is a zinc deficiency, the child develops dermatitis in the acral area, means around the anal canal, around the oral cavity, the child will develop dermatitis, and this is called as acrodermatitis enteropathica. Acrodermatitis enteropathica. Acro means the terminal part, the child will develop the dermatitis in the terminal part, it's called as acrodermatitis enteropathica. Zinc deficiency also leads to diarrhea. That is why in the PSM you have discussed that if there is a deficiency of, whenever the diarrhea patient comes, we give zinc also in the pediatric age group. Selenium deficiency leads to Keshan disease, and Keshan disease will present as dilated cardiomyopathy. When it comes to calcium, the serum calcium is 9 to 11, and there is a relation of serum calcium with QT interval. What is the meaning of QT interval is, from the beginning of the Q wave to the completion of T wave is called as the QT interval. If the serum calcium is less, the QT interval will be more. Serum calcium is also helping in the muscle contraction, is also helping in the formation of the clotting factor, right? So this is what is, I feel, is very important in perspective of this exam. I have tried to be as crisp as possible, and I have tried that we can cover a lot of content in the limited time frame, so that I have taken the screenshot from my notes so that we can cover the things in a very limited time frame. And I will just briefly revise what we have discussed in next 5 to 7 minutes, and that is going to summarize the whole concept. We started with the amino acid. In the first, we have discussed that about the urea cycle, how the urea cycle happens, and if the urea cycle doesn't happen, the ammonia will build up, that is hyperammonia. If the hyperammonia alone is there, it is hyperammonia type 1. If it is hyperammonia with orotic acid urea, it is hyperammonia type 2. Then we have discussed about phenylketone urea. Deficiency of phenylalanine hydroxylase leads to phenylketone urea. The child will have bad smell in the urine, will have the decrease in the IQ and fair skin complexion. That is phenylketone urea. Then we have discussed about the the pheochromocytoma. 3 question came last time. Tyrosine converts into norepinephrine and epinephrine. If that happening excess, that is seen in pheochromocytoma, there is going to be more sympathetic activity. The symptoms are going to be episodic, and once the tumor will secrete, the symptoms will come, and within few minutes they will go away. When you give the treatment, the first you have to give the alpha blocker followed by beta blocker. If you do the surgery, after that the patient may become dark. That is called as Nelson syndrome. Then we have discussed about the alkaptonuria, very important. Can you tell me what is not a symptom of alkaptonuria? What is not a symptom of alkaptonuria? Can you tell me? Can you tell me what is here is very good? Yes, IQ. What is not is there in alkaptonuria? Mental retardation. Yes, mental retardation is not a feature. There are three features. There are three features in alkaptonuria: darkening of the urine, joint pain, and decrease pigmentation in the skin. Mental retardation is not a feature of alkaptonuria. The enzyme deficiency is Hg oxidase. Then we have discussed about the pellagra, right? Those tryptophan converts into niacin. If the tryptophan is not there, the niacin will not be made. The first symptom of pellagra is going to be diarrhea, followed by dermatitis, followed by dementia. If the tryptophan is getting lost in the urine, it's called as Hartnup disease. Tryptophan getting lost in the urine called as Hartnup disease. Then we have discussed that the tryptophan also converts into serotonin. If there is excess serotonin is getting made, because of that, this is called as carcinoid. In that, the patient will have diarrhea with flushing, carcinoid. Then we have discussed about histidine. Histidine converts into histamine. This reaction is decarboxylation. This reaction is decarboxylation. And one test that we do to check the vitamin B9 deficiency, it was histidine loading test. Histidine loading test is done to detect the vitamin B9 deficiency. Then we have discussed about the maple syrup urine disease. It was due to branch chain alpha ketoacid dehydrogenase. The patient will have the burnt sugar smell, and the main reaction is defective oxidative decarboxylation. Then we have discussed about homocystinuria. That was your exam question last time, that it is due to deficiency of cystathionein beta synthase. Homocysteine is a very bad amino acid. It leads to atherosclerosis. It leads to DVT. It leads to dementia. The blood becomes very thick. And how the patient will present? He will have the marfanoid habitus. If there is a marfanoid habitus with the bad things, then it is going towards the hyperhomocystinemia. Coming to cystinuria, cola in the urine is called as cystinuria. The patient will present as flank pain. The patient will present as flank pain. Then we have discussed about the arginine. Arginine makes the nitric oxide that is going to work via the cyclic GMP. If that is not there, the endothelial cells are not working. Whenever the patient will go in the winters, there is going to be chest pain. That is called as Prinzmetal angina. Prinzmetal angina. Then we have discussed about the Alport syndrome and Goodpasture syndrome. In Alport syndrome, the type 4 collagens are defective. That is called as Alport. If the type 4 collagen is normal, but the wrong antibody is destroying this collagen, that is called as Goodpasture. The symptoms of the Goodpasture, it is going to be hemoptysis and hematuria. Hemoptysis and hematuria. Then we have discussed about the scurvy. In scurvy, we are going to have the pseudoparalysis because the vitamin C is not there. The blood vessels are very fragile. Most commonly, they ask the question from the radiology part, and that is the ring epiphysis, the white line of Frankel, Trummerfield zone. These are the points they ask from the scurvy. Then we have discussed about the dietary fibers. There are two types of dietary fibers, the water soluble and the water insoluble one. The water soluble ones are the mucin pectin gum, and the water insoluble ones were the cellulose, hemicellulose, and lignin. And lignin was one of the water soluble, water insoluble. That is one of the dietary fiber which is neither digested nor fermented. That is lignin. That is lignin. Then we had discussed about the various type of GLUT. The insulin dependent GLUT is GLUT4, found at three places: adipose tissue, skeletal muscle, cardiac muscle. GLUT2, where it is found in the beta cells. We have discussed about SGLT1, SGLT2. SGLT1 is helping the absorption of the glucose in the intestine. SGLT2 is helping the absorption of the glucose in the nephron. In the diabetes patient, we doesn't want this to happen. We want the glucose to be gone out. So we don't want the SGLT2 in diabetes. So we stop the SGLT2 by giving a drug, gliflozins. Anagliflozin, empagliflozin, dapagliflozin. If you give the gliflozin, the glucose will go out. But because of that, the urine becomes sticky. The patient will develop UTI. Then we have discussed about glycolysis. Glycolysis is a 10-step process. There is going to be generation of 7 ATPs, and the rate limiting enzyme is going to be the PFK1. We can inhibit the glycolysis by giving a toxin, sodium fluoride. Sodium fluoride inhibits the enzyme enolase. Then we have discussed about the Krebs cycle. Krebs cycle. Krebs cycle is going to occur in the mitochondria. It is going to give us 10 ATPs, and there is a toxin which can inhibit the Krebs cycle. The name of that toxin was malonate. It is not malate, it is malonate that inhibits the succinate dehydrogenase. Then we have discussed about the glycogen metabolism. Whenever there is extra glucose, this extra glucose is clubbed together and we make the glycogen. And whenever we are hungry, when we don't feed, when we don't have the meal, the glycogen will break down and we'll get the glucose back. That is called, and if this process is not happening, there are certain disease happens, von GRK and McArdle's. We have discussed these two. One GRK में, the child will have hypoglycemia. Whenever the child is fasting, having hypoglycemia, one GRK. In the McArdle's, we have taken the example of Rakesh that if a person is doing physical exertion, this physical exertion is followed by severe muscle pain, followed by the pain in the flank area, followed by dark colored urine. That is called as McArdle's. That is due to deficiency of muscle glycogen phosphorylase. Then we have discussed about the galactose means galactosemia. If they say that whenever the mother is giving the breastfeed, the child is having vomiting, galactosemia. The mnemonic that we have discussed was FAB gut. Galactosemia is due to deficiency of uridine transferase, and in that the child will have early drop cataract, decrease in the IQ, breast milk followed by breast milk followed by vomiting. The child will have jaundice. That is galactosemia. If the fruit juice is creating the trouble, fructose intolerance, it is due to deficiency of aldolsp. Aldolsp. This is what all we have discussed in the carbohydrate. Then we have discussed about the Gaucher disease in the lipid chapter. Gaucher disease basically is due to deficiency of beta glucosylceramidase. There is going to be anemia with hepatosplenomegaly. Anemia, hepatosplenomegaly, Gaucher. If they say the word angiokeratoma, angiokeratoma means it is going towards Fabry disease due to deficiency of alpha galactosylceramidase. Here I am adding one more point. If they say that we have given a drug, say for example primaquine. If they are saying that we are giving primaquine, after giving primaquine, all of a sudden the patient develops anemia. After giving a drug, the patient is developing anemia. They are talking about G6PD deficiency anemia. If they say giving a history of drug and after that the anemia is happening, it is G6PD, and G6PD is X-linked recessive disorder. There is bite cells are seen and Heinz bodies are seen. Heinz bodies are seen. This is G6PD, right? Then we have discussed the various lipid disorders. The type 2 lipid disorder was familial hypercholesterolemia. In all the 5 family members, the cholesterol levels will be high. That is familial hypercholesterolemia. So now will not take you much of the time. I will just want to share a few things with you that as you are preparing for 20th Gen and today is the 6th Gen, what I want you to say is, don't worry that how much will be completed till 19th Gen. It is not that what is left, it is not important. What is important is what you have learned, how good you are in that, how much you are able to apply those concepts. This is very important. Be relaxed. Everything cannot be completed. Even if you get one more year, everything cannot be completed. You know enough. You can easily clear the exam if you do not do the mistakes in the easy questions. If you make sure that you are doing the easy questions right, you are definitely going to pass. It's just a matter. It's just a matter to control the nerves and the mental toughness. You have enough to clear this exam, but what is lacking is we are making the mistakes. Even if you have seen in your GT scores or the test scores, what is happening there? If you evaluate whatever score you are getting, be it 150, 140 or 190, whatever you are getting, you could have scored 20 odd marks more. When you do the analysis, you know that how many silly mistakes you have did. Just imagine that when it will be real exam, in that real exam, how much pressure will be and how much silly mistakes we will do, right? We need to learn that. We need to minimize that. If you minimize your silly mistakes, no one can stop you in clearing this exam. It's just a matter. See, there will be many difficult questions. I am not saying that everything will be easy, but there will be easy questions also and that is going to make you pass. So whether it's a difficult question or easy question, both give you 1 mark. Both give you 1 mark. The probability of a difficult question to be get corrected, it's less. Easy questions, which you know, it's more probable that you will make it correct. So you should invest more time in that. But in exam, we are doing reverse. We are giving more time to the difficult question. We are reading them word by word. But in the easy question, we are directly jumping to the answer. And there we are making the mistake. Majority of this. So Focus on the easy question, focus on the easy part. Whenever you see a easy question, make a habit that read that question twice, thrice, and make sure that you are making it correct. And no one is going to stop you in clearing this exam. Definitely, you can easily clear this exam. Two things you have to make sure. The next 2 weeks, you give your best. Don't worry that what will be left. See, if you have not done a lot of things, whatever you do, if you are good in that, you are going to clear the exam. So whatever you don't make big schedules, just make a small target that okay, for next 2 hours I am going to study ENT. You study ENT. After 2 hours, again you decide that what you want to do. If you want to continue ENT, continue ENT. If not, do something else. Make small 2 hours target. Don't make huge big schedules. They never works. They will fail on the next day. Even on the same day evening they are going to fail. You will understand it's not working. So what you need to do is tell your brain that you are not going to listen to you are not going to make any big schedule that this much should be done today, tomorrow, day after tomorrow, and this way. No, I'll just read for 2 hours. I will give my best for 2 hours, then again next 2 hours, then again next 2 hours. I will not think that how much will be left. I will just take care of the things that whatever I am doing, the MCQ will not go wrong if the question will come from here. And I bet you that no one can make you fail. Definitely you are going to pass if you do that. And every day, at least do 50 MCQs. Every day, at least give 50 MCQs. And now don't go into any GT part. Because GT takes at least one day. Complete West means you do 300 MCQ, then you do the analysis, then you get your score, and then you get either you means if you get a very good score or a very bad score, you just think of that score, you are try to interpret in that score, and we waste a lot of time. So I would suggest that max to max, if you want to give a GT, give one more GT before 10th. After that, no. And the every day, but try to solve MCQ every day. At least do 50, 60 MCQ. Make sure that in the 12, 13, 14 subjects where you are very good, make sure that you are very strong in that. On 19th of January, I want that you read till 9 p.m. And what you have to do, what you have to read on that day, take your all the notes. Start with the notes where you are very good. Open that. Start flipping the pages. Just read. Just read. No need to cram. Just read. Put aside. Second book. Read fast. No need to read even every line. Maybe some lines are highlighted. Just read that and okay. You know, put it aside. Put it aside. Do it. As much as pages you can flip on 19, do that. It's going to boost your morale a lot in the exam. That just now you have read these notes, the next day you are going to perform very well. The next day you are going to perform very well. So it was very nice. It was very nice to interact with all of you. It was very nice to interact with all of you, and I want you to I want you to connected with you. If you have anything you want to ask or any doubt is there regarding your preparation or particular subject wise, you can write me there. We'll try to answer that. Right? Wish you all the very best. Let's rock the exam. You know enough, and definitely you are going to make it happen. It's just a matter of some time. It's just a matter of some time, and you can easily do that. You can easily do that. Right? Wish you all the very best. Thank you.